2 to 3 decades have been characterized by an uptick in opioid prescribing, overdose deaths, and persistent use after surgery. So like many other surgical departments, we began assessing our own prescribing patterns and implementing measures for more judicious opioid use through a 4-pillar approach, which included both patient and provider education, limited inpatient opioid exposure, aggressive and purposeful pre-discharge opioid weaning, and standardizing discharge prescriptions using our 5-time multiplier algorithm. We performed this study to assess the effects of expanding opioid reduction efforts after pancreatectomy on the opioid volumes prescribed after hepatectomy over a 7-year, 5-era period. The results were striking. We observed a more than 50% reduction in both intraoperative and total inpatient oral morphine equivalents. At discharge, there was a 73% stepwise reduction in OME between the start and end of the study period. We universally adopted a routine 3-drug non-opioid regimen and observed a 5-fold increase in the number of patients discharged opioid-free. Median inpatient pain scores stayed the same. Readmission rates were consistent with previous years, and the overall rate of refill requests was low, suggesting no adverse clinical effects of these interventions. We then tabulated the number of opioid pills, specifically 50 milligram tramadols, that were saved after hepatectomy alone with these changes, and found a staggering 91,668 pills were saved. When placed side by side, that's just over half a mile of tramadol. That's equivalent to the height of nearly 3 Eiffel Towers, 2 Empire State Buildings, and of course, the Burj Khalifa. Findings of this study suggest that gradual, yet directed, opioid reduction efforts within a surgical department can have a sustained department-wide halo effect and provide evidence that low opioid and opioid-free discharges after major abdominal cancer surgeries are both feasible and safe.